Hello everybody, very good morning. Myself Dr. Neeraj Goyal, surgeon by qualification, a sports enthusiast, TEDx speaker and a student of life. Today I am going to share thoughts on role of Tripsin, Bromelain, Rutoside in venous ulcer. So as far as my experience on myself is concerned, I am working with Max Hospital in New Delhi and has been more than 20 years in this field of surgery, especially laser surgery for proctology, varicose veins, other applications of laser, laparoscopic surgery, robotic surgery and many more. So starting with today's discussion on insight to chronic venous disease. See, general venous insufficiency of the lower limb extremities results in chronic venous disease. We all know that. The global prevalence of the disease is 73% in females and about 56% in males. It causes a derogatory impact on the quality of life and imposes financial burdens as well. Symptoms of chronic venous disease, as far as symptoms are concerned, they include dark blue blood vessels in the limbs, aching, discomfort, pain, or even tenderness around the vein, tired legs, especially in the afternoon and the later part of the day, with heaviness because of the engorgement of the blood inside the vessels, even numbness, swelling, itching, burning sensation in the legs are complained very frequently. Night cramps, pigmentation, bulging, rope-like bluish veins, very distressing, especially for females and all those who are wearing clothes which are exposing their legs. Chronic venous disease and chronic venous ulcers, they develop as a clinical manifestation of these CVDs, that is chronic venous disease. So when we examine such patients, the signs, the examination findings are telangiectasias, reticular veins, varicose veins. They may involve any part of the leg or lower limb, only confined to feet, legs, thigh or the whole limb. Edema, skin changes, hyperpigmentation. Venous eczema, lipodermatosclerosis, very common. Then atrophic, blanched or healed or active venous ulcers in the end as a result of ischemia to an extent where ulceration happens. Now, what are the risk factors for developing these chronic venous disease? Who are those people who are at higher risk of developing these? These are as the age advances, because of the verticality of our posture, female gender, obesity, unnecessarily the veins are required to work more because of the extra fat that the legs or the body has. So, the blood is travelling against gravity. A positive family history, pregnancy because of the gravid uterus, mechanical compression, also the hormonal effects on the smooth muscles of the vein walls, phlebitis, previous leg injuries of specific types, prolonged standing, even sitting posture for prolonged period, impairs venous return. Now, chronic venous ulcer is one of the commonest and most serious manifestations of chronic venous disease. The prevalence of venous ulcer is 0.3% approximately, and active or healed ulcers are seen in about 1% of the population. Now, talking about the pathophysiology of chronic venous ulcer. How does these chronic venous ulcers develop? Elevated ambulatory pressure of the peripheral venous system, the veins in the limbs we are talking about. It leads to impaired microcirculation, that is one change, and second is microangiopathic change. Impaired microcirculation has effects like alteration of the walls and valves inside the veins. Venous hypertension happens, varicosities develop, edema starts, ultimately leading to leg ulceration. So, these are the gradual changes because of microcirculation changes, impairment. Now, the second change is microangiopathic change. What does this microangiopathic change do? It leads to reduced vascular reserve inside the veins, in turn decreased skin's oxygen content. And when these are there, what will this lead to? This will lead to elevated subcutaneous flow and capillary changes. So, compensatory phenomena leading to all these things. Now, both these changes, they lead to leaking of the fibrinogen from the epidermis of the dilated vessel wall, and fibrin cuff formation, which subsequently causes trapping of growth factors and matrix. These in turn lead to blocked oxygen and nutrition supply to the tissue. Ultimately, we can understand when oxygen is not there, nutrition is not there, ulceration, that is ischemic ulceration, or because of the deprivation of these, ulceration has to happen. Breach in the continuity of the skin. Management of chronic venous disease. Fine, we have these changes, how to manage this? Very, very, very important. The action point. Goal of chronic venous disease management is to improve symptoms, prevent further complications, sequel, and encourage ulcer healing. So, these are the aims, the goals. No rocket science for this. Now, the options that we have to manage these CVDs are conservative management in the form of only compression therapy, stockings, crepe bandage, pharmacological therapy, some medicines are available, and exercise therapy. Lower limb elevation is also a very important part in the management of these CVD patients, because the underlying cause was against gravity blood flow. So, we make it pro gravity, put something to raise your calf muscles up and it helps the gravity. In the second option in the management after conservative management are interventional methods, which include sclerotherapy, endovenous laser ablative therapy, endovenous deep system therapy. So, these are relatively minimally invasive office procedures. But if those patients who end up in delayed complicated stages, not having resources of these advanced treatment, the other options are in the form of surgery for the veins or venous tributaries, perforator veins surgery, valve reconstruction, Trendelenburg operation, phlebectomies, stripping of the veins. All these options are there, and there are also some vascular procedures which we can do. So, we come to the chronic venous ulcer and systemic enzyme therapy now. Where is the role and how this systemic enzyme therapy work in these patients of CVD, which is a very large number of population who are suffering from this disorder. So, before talking about the systemic enzyme therapy, what is the need of systemic enzyme therapy? It is needed when venous ulcer lesions are non-responsive and persist despite conservative therapy. These patients are so troubled, their family, they are thinking that this is just like a normal wound, and they are applying dressings, they are saying treatment is going on, still it is not healing, rather it is increasing. Why? Because the underlying cause is not treated. So, underlying cause CVD fine, but what about ulcers? So, when the ulcers are not healing, there is a role for these systemic enzyme therapy. It is also required in cases of greater relapse after following surgeries, because it is not uncommon that you treat by surgery, but residual segmental diseases they appear. The patients, they come with some veins at places which are not completely resolved, because the venous drainage of the lower limbs is a 3-tier system: the deep venous system, the superficial venous system, and the communicating or perforating veins. So, it is not that simple that single line vessels are there, single plane vessels are there, and you just treat by one surgery and it is over. Deep veins always remain. So, they or the perforator, they can always present us with residual disease. There is an increased need for treatment modalities that can treat microcirculatory disorders and act on chronic inflammation in the ulcer. Constant leukocyte infiltration is there, which needs to be controlled. Changes in the metabolism of the endothelial cells. So, these are the changes at cellular level which need to be managed, where these therapies, they play a good role. Now, some quick factors about systemic enzyme therapy. It is an enzyme flavonoid combination administered by oral route, which has demonstrated favorable results for chronic venous disease management regarding its efficacy and tolerability. Systemic enzyme therapy is a combined form of enzymes which are Tripsin and Bromelain together with bioflavonoid Rutoside. This combination is available in varied formulation across India, dispersible, entry-coated, and in various strengths. So, what is the significance of this combination? The beneficial effects of systemic enzyme therapy on chronic venous disease pathology are that vasodilation and increased vascular permeability is mediated by histamine. You tap the vessels here and the vessels dilate. So, this chemical which is released on this kind of a change is histamine. Bradykinin is there, and fibrin degradation products, FDPs. Now, bromelain reduces vascular permeability by depleting kininogen, which is required for producing bradykinin. Rutoside helps to reduce vascular permeability by inhibiting nitric oxide production through attenuation of INOS gene expression. Now, dilatation of vessels takes place after leakage of fibrinogen from capillaries, we already said, which coagulates and hardens to form a fibrin cuff. What is the role of trypsin? Trypsin displaces bound plasmin from plasma proteins, and the free plasma mediates fibrinolysis. Bromelain helps fibrinolysis by proteolytically converting plasminogen to active plasmin. So, if you can understand this pathological change at cellular level and chemical level, we can understand that these salts, these enzymes do have a very strong role in working at that level. Stasis of blood and damage of blood vessel wall predisposes fibrin formation and platelet aggregation leading to thrombosis. Here comes the bromelain. Bromelain inhibits platelet aggregation by inhibiting adhesion molecules on the platelet surface. Rutoside prevents platelet activation by inhibiting intracellular calcium mobilization in platelets, and which is required for platelet activation. So, in this manner, rutoside prevents the platelet activation. Now, increased leukocyte migration, the white blood cells, to the site of inflammation. We know the army in our body, the immunity is by leukocytes. Bromelain alters the cell surface molecules that are involved in leukocyte cellular adhesion to prevent leukocyte migration. Rutoside inhibits the transcription of genes encoding for chemotactic factors. So, you can imagine now when these enzymes are working like this, definitely the healing or the outcome of these ulcers is bound to improve. Now, increased production of pro-inflammatory cytokines such as tumor necrosis factor alpha, TNF alpha, and interleukin 1 beta, IL-1 beta. Bromelain reduces cytokine production by altering the cell surface molecules that are involved in leukocyte activation. Rutoside inhibits the transcription of genes encoding for pro-inflammatory cytokines. Release of reactive oxygen species and nitrogen species causing tissue damage. Rutoside inhibits the production of superoxide ions, hydroxyl radicals, lipid peroxy radicals, as well as INOS mediated nitric oxide. Now, continued inflammatory changes and venous stasis results in chronic non-healing ulcers. Tripsin, by activation of PAR1 and PAR2 receptors on macrophages, promotes the differentiation of macrophages to a more healing or repairing profile, that is macrophage 2, M2 type of reaction, rather than an inflammatory profile, that is M1 macrophage 1 type of reaction. Efficacy of these enzymes with these medicines, bromelain, rutoside, we are talking about. What is the scientific evidence? Now, the efficacy of this enzyme therapy with these medicines, when it was tested, the work was done in a scientific manner. The aim was to compare these salts of bromelain and rutoside with conservative treatment modalities as wound dressings, compression, phlebotropic drugs in patients with venous trophic ulcers. How was this comparison done? The method was a total of 20 patients were treated with this TBR combination and 18% patients were treated with conservative treatment. That was the control group. So, 20 patients with TBR and 18 with conservative treatment other than TBR. Scoring used for assessment of different parameters, VCSS used for quantitative assessment of symptoms, the ulcer and skin condition score, the analysis of wound healing dynamics was done, and VAS, discomfort in daily activities. Evaluation of bacteriological analysis of ulcer discharge by culture and sensitivity, by microscopic examination, lymphocyte counts, surface receptors before and after treatment. What were the results? The impact of TBR on total ulcer epithelialization was shown as a table, that is table 1. So, table 1 is representation of total ulcer epithelialization. Here 40% patients, they showed total ulcer epithelialization in TBR group by 3 weeks of treatment. compared to control group where it was only 22%. So, a significant gain. And at the end of the treatment, this was at 3 weeks. At the end of the treatment, 90% patients on TBR, they showed total ulcer epithelialization compared to 50% patients only in the control group. The relief in pain and discomfort around the ulcer were expectedly more significant in the TBR group versus the control group. A decline in regulatory T cells and an increased memory cell level was seen in this enzyme therapy treated group by immunoassay. Based on these findings, the conclusion of this study was that TBR, the combination of these three medicines, molecules, salts, it processes regeneration in damaged tissues and positively impacts T cell mediated immunity in cases of varicose veins, accelerated healing of venous ulcers and reversal of clinical symptoms. Now, effects of Bromelain in patients with CVD now. A large prospective study investigated the effects of Bromelain combined with other agents in CVD patients. A total of 648 patients here were enrolled. Out of 648, 165 patients were treated with compression stockings, the conservative treatment. 252 patients were given compression stockings plus combined form of Bromelain, and 231 patients received only Bromelain in combination form. So, these three groups, what were the results? The results were the patient group receiving Bromelain plus compression stockings and monotherapy of the combined form of Bromelain showed significant relief in symptoms versus the patient group treated with only compression stocking. Similarly, efficacy of Rutoside in treating venous insufficiency. Study 1. A randomized double-blind placebo-controlled study analyzed the effects of Rutoside. Total of 40 patients were treated here with Rutoside and 20 patients with only a placebo. The treatment duration was 4 weeks. What was the result? The result was Rutoside treated group showed more effective symptom reduction versus placebo. Rutoside had good tolerability and no side effects. So, the conclusion was Rutoside was effective and well tolerated. Second study. Another randomized placebo-controlled trial studied the efficacy and tolerability of Rutoside and placebo in patients over 65 years of age with venous insufficiency. Here, a total of 104 patients were enrolled. Assessment of tolerability and efficacy was done in 102 and 86 patients respectively. Methods. The treatment continued for 6-month treatment with monthly examination. What was the result? The result was significant improvement in cramps and heaviness of legs, restless legs, very common syndrome with Rutoside versus control. Significant reduction in ankle and calf circumferences because swelling, the changes, petechic edema of the leg was less, eczema of the leg with Rutoside versus control. Therefore, the conclusion is Rutoside is both effective and well tolerated in treating venous insufficiency. How about severe CVD and associated complications? So, efficacy of Rutoside was studied for severe CVD and associated complications. The aim here was to evaluate the efficacy of Rutoside in complication prevention in cases of severe CVD and venous microangiopathy. The method used was 4 different groups were made. CVD patients without diabetes mellitus, they received 1500 milligram per day of Rutoside. Second group of patients, CVD patients and diabetes mellitus together. They received 2 gram of Rutoside per day, and there was a control group where no treatment was done, and fourth group was only compression stockings treatment was done. Now, evaluation of venous ulcer and CFR with a clinical score scale was done, and the results were there was significant reduction of CFR in Rutoside related group with an even greater decrease with a higher dose of Rutoside in the CFR group. No adverse events were seen. So, the conclusion was Rutoside effectively prevents ulcerations and manages complications in the distal venous system with the demonstration of long-term efficacy and tolerability in CVD patients. After all this understanding, I would like to mention the key highlights. So, chronic venous ulcer is one of the most frequent and serious sequel of chronic venous disease, a very well known fact. The painful symptoms of chronic venous ulcer impact ambulation and affect the overall quality of life. The QOL is significantly impaired and affected. Systemic enzyme therapy including Tripsin, Bromelain, Rutoside has emerged as a promising management of venous ulcer, which is supported by scientific studies. Now, benefits of these TBR combination in venous ulcer. So, Tripsin, Bromelain, Rutoside reduces vascular permeability and enhances plasmin mediated fibrinolysis. TBR inhibits platelet aggregation and platelet activation. It also inhibits transcription of genes encoding for chemotactic factors. TBR promotes the differentiation of macrophages to a more repairing profile and promotes the healing of chronic venous ulcer, the M1 and M2. Oral dispersible tablets with enteric coated granules for TBR combination provides maximum drug bioavailability and efficacy. Rapid and greater drug absorption with a rapid onset of action. It helps in better patient compliance when compared with conventional form. We very well know that. Thank you so much for being with me throughout this evolution of science. I always believe very strongly that if we are not updated, we are outdated. Mankind and science have always proved this thought wrong, that whatever we have achieved is the pinnacle of life or achievement. There is always a lot of scope to go ahead, provided we can keep our brain and hands open. Thank you so much.